Well, welcome to the introduction on oxygen. We're just going to talk a little bit about oxygen. How do we transport it? How do we measure it? What are some formulas that can give us some pretty good indications of what's going on? And then a little bit of the uses of oxygen. We're going to address hypoxia with one or two slides. And then on the next lecture, we're going to talk a little bit more about hypoxia. So remember, we've talked a little bit about the alveolar air equation. This basically tells us how much oxygen is available for diffusion from the alveoli into the arterial blood. It also helps determining the physiological causes of respiratory disease. It tells us if there's a problem, because if we're not getting enough oxygen out of the lungs and into the arterial blood, then there has to be a problem somewhere in the lungs, and we need to go looking for it. Okay. Some of the other things we can use this for is for some of the equations. And you have two equations here. The first one is called the A to A gradient. This is determining how much is available and how much got across, and the difference is how much is still left behind. The little a to big A is your A to A ratio. That just tells you what ratio, or look at it as percentage got across compared to what was available at that particular point. Except for the little a to big A, these other formulas are really tied into the FiO2. So there it is, the P big A02 in the lungs. It determines what's available to go into the PaO2. And we've seen this formula before. Remember that your pH2O, your 47 millimeters of mercury, has to be removed when we're doing alveolar oxygen, okay? Remember, if you're just doing the ambient air, the 47 stays in the formula. Remember that 1.25 is your respiratory quotient. If you don't want to multiply by 1.25, you can always divide by 0.8, and it works beautifully. This also tells us a little bit, as you can see down here, that's affected by alveolar hypoventilation. If your patient is not breathing, then we're going to have an issue because we're not going to be getting a lot of oxygen across. So a little bit more on the A to A gradient. You're going to either see it written with the P big A minus LaO2, or I've also seen it with the big A little a DO2, and that's your difference of oxygen. And with young folks, the kids and things, it's normally like 5 to 10 is left behind. As we age, it varies with our age. One of the things that you probably remember from pulmonary A&P is that as we age, our lungs become a little bit more saggy-baggy. We start to have some problems with them. And so as a result of that, the amount of oxygen that diffuses across the alveolar capillary membrane actually decreases, okay? However, the norm for the most part is like 10 to 25 millimeters of mercury on room air. That should be the difference. On 100% oxygen, somewhere around 25 to 65 millimeters of mercury at that particular point. And we can sort of estimate, I mean, if we estimate, we're estimating on room air, and you can see the formula here is age divided by 4 plus 4, and that gives us an indication about how much of that should have gotten across. So the one formula, there's your A to A. It's the difference between what's available in the lungs and the alveoli, and actually how much of it did get into the arterial system at this particular point. And the difference between the two, as you can see here, is how much did not get across. And when we get into a mechanical vent, we're going to talk about which value is it that tells us that we have a big issue with our patients. Now, this difference can be increased by respiratory failure, ARDS, shunting is a big one, pulmonary edema is another one. We haven't talked about that in diseases, but we are. COPD, we talked that. If you remember, you lose the area for gas exchange. Pneumonia, that was a pretty big chapter also, all the different things that happen with that. It can also tell us a little bit about how bad is the disease at this particular point in time. You can have pneumonia, but if it's not terribly bad, you may not diffuse as much as you need to, but as long as you're diffusing enough to be able to continue the things that you need to do, you're in pretty good shape, okay? And then sometimes it does help us a little bit with hypoxia and hypoxemia, what's going on at this particular issue. And we know that we can increase this difference 5 to 7 millimeters of mercury every time we increase the FiO2 by 10%. I thought this was kind of an interesting slide. I found this on one of the StatPearl articles, and they said you can use it as long as you tell people where you got it. And that's exactly where I got it. These are things that we've talked a little bit about. We didn't talk about high altitude, but you guys know that whenever you go up in altitude, the partial pressure of oxygen goes down, okay? Of inspired oxygen, but remember, oxygen's always going to still be at 21%. And as a result of that, as you go up and that partial pressure decreases, you become more hypoxic and hypoxemic. And we see these with mountain climbers who have to really train well, and they still have to use oxygen. Hypoventilation, a little bit, you can see with this, you can correct that with oxygen. We haven't talked about the neuromuscular diseases, but we're going to. Any skeletal abnormalities in the chest wall. Opiates are a big one, so CNS depression we need to do something with. Diffusion defect, you read a little bit about the interstitial lung disease. We can go ahead and give you some oxygen, and that'll help you in some cases. However, remember with things like fibrosis and things like that, oxygen is not going to help you. There is no way to diffuse it across the AC membrane. VQ mismatches for the most part. Chronic bronchitis, we can give you some oxygen and actually get it across the AC membrane. Mucus plugging, pulmonary edema. If we give you enough and open up the alveoli, we can do that with our non-invasive positive pressure ventilation we're going to talk about in a couple of weeks here, and that will help with it. However, if you have a pulmonary emboli, you've blocked the airway, nothing's getting across, and emphysema is another one too. And then shunting, you cannot just give them oxygen. Shunting is your collapsed airway. You have perfusion, but you have no ventilation, and as a result of that, things are not going very well for you. And you can see on here some of the same diseases that we see above, but these are actually our worst diseases at this particular point in time. And for another oxygen formula, here's your A to A ratio. And as you can see, it's the ratio of arterial oxygen partial pressure to the alveolar oxygen partial pressure that's available. And it basically tells us a little bit about what's going on with your lungs. And you can see like 0.474 to 0.9 is normal. VQ mismatch, anything less than or equal to 0.6. And then a shunt is anything less than or equal to 0.15. We don't normally report these as percentages. We just leave them as they are. Hypoxemia, basically, this is decreased oxygen in the blood. And you guys know from looking at arterial blood gases that you have basically 3 levels or sometimes 4 levels of hypoxemia. It's not really called hypoxemia if your oxygen PaO2 is greater than 100. It's hyperoxia. And sometimes they're redoing the definition of hyperoxia, but normally anytime the PaO2 is greater than 100 millimeters of mercury, that's what we're looking at. So with hypoxemia, the things that we look at, is it mild, moderate, or severe? If it's severe, one of the things you always want to think about is hypoxemia will kill you, and there's nothing you can do about it at that particular point in time. So there's 5 mechanisms for this, as you can see on here. If you're going to go mountain climbing is one of them. If you have a diffusion defect, if you're not breathing well, say we gave you some medication and now you're breathing 5 to 6 times a minute, you are not going to be doing well. We're going to have to do something to help you. There's your shunt again, and there's your VQ mismatch too. And hypoxia, for the most part, decreased oxygen in the tissues. And there's basically 4 types. One is hypoxic hypoxia. That is the most common one. This is what we see with our patients who have COPD. This is what we see when you are doing that mountain climbing up to the top of Mount Everest, and you're not having much partial pressure of oxygen up there. Anemic, that's a loss of your red blood cells. You have a normal PaO2, okay? Stagnant or circulatory, we see that. You also have a normal PaO2. And histotoxic. And we're going to talk about some of the causes of these, but these 3 all have a normal PaO2. The only one that has the abnormal PaO2 is hypoxic hypoxia. So then what we want to look at is how is oxygen carried in the blood? And we have 2 ways, and I know you guys talked about these and back in pulmonary A&P at least. One is we dissolve it in plasma, and the second one is we bind it to hemoglobin. And as you know, the dissolved in plasma is a very tiny portion of what we actually use. The majority of it comes from being bound to hemoglobin. With our dissolved in plasma, we can actually plot this on a straight line that's going up, and we know exactly what's going to come next because it's the same number all the way up. And you can see that at a PaO2 of 100 millimeters of mercury, you have 0.3 mLs per deciliter of oxygen dissolved in the plasma. And how do we plot it? Because we know that for every 1 millimeter of mercury pressure, we're going to be able to dissolve 0.003 mLs per deciliter of oxygen. And the other is you're bound to hemoglobin. Like I said, this is the major one. This affects whether or not you're going to have enough oxygen. We need to be able to bind it, okay? And in this case, we need to remember each gram of hemoglobin can carry approximately 1.34 mLs of O2. Now, if you like to look up things on the internet or you like to go into the professional journals, if you read some of those journals, especially coming from the European theater, they're going to tell you instead of 1.34, it should be 1.39. However, when you take into account everything else that happens in the lungs, by the time you get through, you're back to either 1.34 or 1.36. What we do is we just use the 1.34. This is a non-linear relationship, though. You cannot plot this on a straight line because of the changes in the hemoglobin, okay? And we also are going to use the SaO2, which is your saturation. Remember, we need to get that from our ABG, and you can see there is a formula that we can go ahead and actually figure this out. And this is a good place to remind you, remember when you're talking SaO2 and you're looking for approximate PaO2 to go with it, 456, 789. 456 is the PaO2, 789 is the approximate SaO2. And the board has got a really good way of asking this question on occasions, but they'll basically say, what is the approximate? And it'll either be the SaO2 or PaO2 when whatever value that you're not looking for is what's going to be given to you. This happens to be one of my favorite curves. I've found out, that you can do a lot with this curve. I know when we first learn it, it's like, oh, you kidding here? I hope I never see this again. Unfortunately, you will see it. You're going to see it second semester, third semester, fourth semester, fifth semester. Tammy loves this curve also. And as you remember with this curve, there's things that cause it to do a left shift. There's things that cause it to do a right shift. And this one is sort of giving you 2 of them. One is pH and the other is temperature. And we just have to remember this because our blood gas values are also reflected in this. So when we're looking for the content formulas, what we're going to talk about is basically how much oxygen is available in the alveoli. And we know that we can figure the approximate out, which is your P big AO2. But we also want to know how much can be delivered if you're going to dissolve it in plasma or bind it to hemoglobin. And what we're going to start with a little bit backwards is I'm going to actually start with the arterial O2 content. And remember, the two formulas, they don't change. It doesn't matter if you're doing the CCO2, which is your N capillary, which is your P big AO2. Doesn't matter if you're doing the arterial O2 content, which is what we have up here on the slide, nor does it matter if you're doing the PVO2, which is your true mixed venous. The normal arterial O2 content, somewhere between 16 to 20 grams per deciliter, or vol percent. And vol percent sometimes is an easier measurement to remember. In order to be able to do the arterial O2 content, you have to be able to get a blood gas from your patient, and that will tell you the numbers to be able to plug in. So again, the formula is going to be P little AO2 times 0.003. And as you see, there's several examples here and one for you to work. For bound hemoglobin, 1.34 times hemoglobin times SaO2, and that's where we're going to find out how much is bound to hemoglobin. And as you can see, some of the formulas have been worked for you. You can see on this first one, if you notice, it's a little low, okay? And the question comes up, why is it so low? And the answer is, take a look at your hemoglobin. A normal hemoglobin is what, 12 to 15 grams per deciliter for females, 14 to 16 grams per deciliter for males. This is a little bit low at this point. And if you look at the next one, you can see that the answer is like 20.72. That's a little high, it's okay, but it's a little bitty tiny high, and you're going, oh, okay, what's the problem? The SaO2 looks really good. Look at your hemoglobin, it's 17 grams per deciliter. And here's one for you to work out. And so in order to find out exactly how much we're looking at here, we want to know the total O2 content of arterial blood. We're going to add both of these together, okay? And for this one, this is for you, a problem for you to work out. And there it is. Adding the two together gives you the content of arterial oxygen, tells you the overall carrying capacity of arterial blood, okay? And we're going to look at the parts that make it up. What is your PaO2? If it's low, you're not going to have a whole lot of oxygen to bind the hemoglobin either. If it's high, then sometimes we don't have to worry about it. When we talk about the hyperbaric oxygen, basically that is a lot of PaO2. And sometimes we don't really worry too much about what's bound to hemoglobin because we have a lot of oxygen that we're giving this patient. We also need to look at that hemoglobin. Remember, we looked at those two problems there. Is it normal? Is it not normal? Is it high? Does this patient have polycythemia? If it's high, you know, what are we going to do to watch that? Because remember, polycythemia is really, really hard on the heart, and it can cause clotting and other negative effects on the body. Or is it really, really low? And why is it low? What's going on with this patient? Are they bleeding out? Is there something else that's happening at this particular point in time? And if that's happening, we got to do something to stop it, because otherwise, once they get extremely hypoxemic, their life expectancy is decreased a bit. And there you can see it is affected by anemia and hypoxia and polycythemia. The other part of the next one now is the mixed venous content. In order to be able to use the classic Shannon equation that we're going to talk at the end, you need the true mixed venous. And the only place in the body where you get a true mixed venous is in the pulmonary artery. And remember, because people who don't understand this, and even we forget it on occasions, is that the pulmonary artery definition is it's carrying oxygen away from the blood, the heart. And when it's carrying it away from the heart, it's taking it to the lungs. That's your definition of the artery, okay? Formulas, same thing. PbO2 times 0.003 and bound to hemoglobin 1.34 times hemoglobin. In this case, it's CSVO2. Okay, so now we're looking at the venous O2 content. We're using the same two formulas that we used in order to find the content of arterial oxygen. In this case, the CVO2, the norm is 12 to 15 vol%. And what it does, it tells us basically how well the oxygen is being used as it's going through the body. And it's an overall reflection of what's happening at this particular point. If it's too much, are we giving too much or are we not using it? If it's too little, are we not putting out enough or are we using too much at this particular point? So there you can see the SpO2, the end result of the delivery of oxygen and the consumption at the tissue level. And basically to get this, the PbO2, we get it from the PA port of the Swan's gans or pulmonary artery catheter, okay? It's a mixture of the IVC, SVC, coronary circulation, and there you see norm about 38 to 42 millimeters of mercury. SvO2 normal is right around 75%. You will find out if you look in some of your other books that these numbers are just a little bit different. These are the numbers that I normally base what I do off of it. So how do we increase it? Hypothermia, alkalosis, carbon monoxide poisoning. Why does that happen? Well, number one, remember if you're hypothermic, you're not using very much oxygen. If you're alkalotic, you're on that oxyhemoglobin dissociation curve going towards the left. And carbon monoxide poisoning, there's no oxygen really being used at that point because you've pretty well bound your hemes up with carbon monoxide. Decreased if you're cold. If you're cold, you're shivering. If you're shivering, you're using lots of oxygen. Acidosis, there's your right shift, okay? And if you're bleeding or you're hypoxic, we'll see it too. So formulas, same thing. Here's the formula for you to work out. Take a look at it and work it out. Also, how much is bound to hemoglobin when, and you have some formulas to work on this one. Remember, the hemoglobin is a major factor when you're figuring out these content formulas. And then you can just put them together. And capillary O2 content, this is what's available in alveolar, okay? And remember, for the most part, when we're looking at this, you're going to end up with a shunt in the body anywhere. We're not too worried about it. SaO2, we just assume it at 100%. When you're doing this formula, you don't have to use the big SaO2 in it. You can just the 1.34 times the hemoglobin because anything multiplied by 1 is itself as it is, okay? And there's a couple of them worked out for you to go ahead and take a look at. And then we look at the classic shunt equation. And the shunt tells us what kind of good shape or bad shape is this patient in. And the shunt equation is basically QSQT. Cardiac output is being shunted over how much you put out, which is your total cardiac output. Normally, we take anything less than 10% as being normal. We're not too terribly concerned about it. Mild is 10 to 20%. We're starting to get a little concerned at this point. Moderate is 20 to 30%, and severe is anything greater than 30%. Moderate and severe, we're really concerned. So here's a problem showing how it's worked out on a couple of them here, and then one for you to work out also. Then the last thing, well, not basically last thing in the world, but one of the last things we look at is your CaO2 minus your CvO2. What's the difference? What did we send out? What did we get back? And the norm for this, as you can see, is approximately 5 vol%. If it's more, we need to know what's going on. If it's less, quite a bit, we also need to know what's going on. And as you can see, it has a direct relationship to how much oxygen that we're actually using, and then an indirect one to how much did you send out. And so there's a few in here. It's a little high here. That's a major high here. And then another one, also a major